Okay, I thank you for participating in the anatomy and physiology section. I hope that was exciting for you all. Now that you know what the inner ear does, that it helps us see clearly when we move, that it helps us align our eyes when we're still, that it helps us have balance without us having to think about it, that it helps control our neck and our head movements without us being aware. And you learned about the central vestibular system and how it helps with compensation. What we're going to do is actually go on and talk about specific problems that cause dizziness. So what I'm going to do is share with you all what I see in the clinic most of the time. So as we look at our kind of big picture slide, see if I can get to it here. We look at our big picture slide here. We've now gone over kind of the big picture of all the different things that can cause dizziness and what vestibular rehab is. We talked about some of the most common causes of dizziness, what we tend to see. And now we're going to go to the 4 diagnostic categories within the pathophysiology section that we're going to cover now. Before I go there, I want to just briefly say that this slide is a better slide than what I showed in the last video. This kind of explains the life of the vestibular system graph, ear function on the y-axis, time on the x-axis. 100 spikes per second is normal ear function. That's where this green line is, the person moving along normally. Boom, they go to the pit. And we're going to talk about what takes people to the pit. Usually it's vestibular neuritis or labyrinthitis. When there's that huge, fast loss of vestibular function, the person is going to spin like a top. That's why we call it the pit. It's a terrible, terrible place to be. It's very intense. And then what has to happen over the next 4 to 6 weeks is vestibular compensation. And we'll go into what that actually is more here soon. But I wanted you to see this slide because I use this when I teach patients. I write this out for them so they know how vestibular compensation takes place, which leads us to what causes vestibular rehabilitation to fail. And what I like to say, if you look at this picture, it's just a perfect blend of colors put in the right place at the right time. And that's what makes it look beautiful. And vestibular rehab is the same. We've got to pick the right types of therapy to do at the right time. And so that's what I'm trying to do is set up a baseline knowledge for you all to be able to do that. So let's get to the good stuff. Rocks versus stroke. Why would I call this pathophysiology section rocks versus stroke? Well, people think their rocks are loose when they're dizzy, and it's getting to the point where the patients I see, everybody's blaming everything on having their rocks loose. And yet, I think as healthcare providers, we want to make sure that we're not missing anything serious. And deep down, patients want to know that they don't have anything serious going on. So how do you know if their rocks are loose, if they're having a stroke, if they have an inner ear tumor, if they have Meniere's disease, if they have vestibular migraines, if it's their heart? How do you know? Well, I really, really like this slide. It's the 4 diagnostic categories that can be summarized. This was in the clinical practice guideline when I first saw it. It's a very nice summary of the major reasons that people get dizzy. So what I'd like to do is just break them down briefly for you all so you can see what they are. The first one is acute vestibular syndrome. The second is triggered episodic vestibular syndrome. The third is spontaneous episodic vestibular syndrome. And the fourth is chronic vestibular syndrome. Now, these are based on timing and triggers. Timing and triggers. And we're going to get to what that means here in a moment. But acute vestibular syndrome, the timing of that is that patients are going to have intense dizziness for days to weeks. Triggered episodic vestibular syndrome, we're going to have dizziness for seconds, usually less than a minute. Spontaneous episodic vestibular syndrome, you're going to have dizziness that lasts minutes to hours. In chronic vestibular syndrome, you're going to have dizziness that lasts weeks to months. So I have all the names written out on what the different problems are within each category, but I want to suggest that you need to, as a therapist, you need to get very comfortable with these 4 syndromes, because your patients are going to come to you most likely having either been in those syndromes or coming in and out of those syndromes. These are very, very applicable. And if you think triggers and timing, you're going to get very far with helping these patients. So let's just look at these. Under acute vestibular syndrome, things that you need to be aware of are, how do you tell the difference between a stroke and vestibular neuritis or labyrinthitis? Under triggered episodic vestibular syndrome, how do you tell the difference between BPPV versus orthostatic hypotension versus migraines positional vertigo? Under spontaneous episodic vestibular syndrome, you need to know how to tell the difference between a TIA versus a migraine versus like Meniere's. Okay. In chronic vestibular syndrome, you need to know how can you tell if a patient has neuropathy versus bilateral vestibular dysfunction, or a neck issue, or an eye problem, or maybe they're highly sensitive or they have anxiety. So these are common dizzy competitors that I see in the clinic that I have to work through when I'm helping my patients. And I like to say, don't think, are they having a stroke, or is it that their calcium crystals are loose? Think, man, could it be all of these things? Always consider everything. So the real take-home lesson that I hope you remember, if you don't remember anything else about this section, is that the big 3 is key: triggers, timing, and nystagmus. When you want to figure out why your patients are dizzy, think triggers, timing, and nystagmus. Triggers, the reason these are important is because it helps you figure out which syndrome your patient could be in. So let's break this down a little bit. Acute vestibular syndrome is not triggered. It is exacerbated, but it's not triggered. You can't move and cause acute vestibular syndrome to happen. I will say, unless there's a vertebral artery dissection of some sort that could cause a stroke, other than that, there is no way that you can trigger acute vestibular syndrome. Okay. Triggered episodic vestibular syndrome, yes. Every time the patient moves, they bend over, they tilt their head back, they roll over, they lie down. That's triggered. Spontaneous episodic vestibular syndrome can't trigger that. Okay. Again, it can be exacerbated. So for instance, if you're in acute vestibular syndrome, you're already spinning like a top, you move your head, you're going to make the symptoms worse. But there's a difference between exacerbating or making the symptoms worse and actually triggering and causing the dizziness to occur at the same time. So as you're listening to this stuff, I'm trying to present this in a way where when you're taking a history, you've got to be able to figure this stuff out. You've got to figure out, is your patient saying that their dizziness is made worse, or that their dizziness was made worse, like it was exacerbated? Did they have dizziness at baseline, or is it actually that something triggered their dizziness to come on and was more intense? There's a difference. So then chronic vestibular syndrome, these are cases where they could have visual dependence, cervicogenic dizziness on someone who's had acute vestibular syndrome 6 months ago, but they never healed from it. So it can be both triggered and exacerbated. So very important. And I want to give credit to Edlow, Gurley, and Newman Toker. Newman Toker has done a ton of amazing research, and these guys were the first to create these diagnostic categories. So I think that's important to point out. Now, the next thing is timing. Timing is very important. And the timing is, how long do the symptoms last, and when did they start? So acute vestibular syndrome, days to weeks. Triggered episodic vestibular syndrome, seconds. I know we already covered this, but it can't hurt to cover it again. Spontaneous episodic vestibular syndrome, minutes to hours, and chronic vestibular syndrome, weeks to months or longer. So very helpful to know these key parts of these problems. So let's dig in more. Before I go there, I want to jump right back to this slide. So what we're talking about is If you want to know what's wrong with your patients who are dizzy, you have to explore triggers, you have to explore timing, and you have to look for nystagmus. These three will help you identify which category your problem is in or has been in. Okay, so let's dig into acute vestibular syndrome first. Acute vestibular syndrome, a person who's going through this, they are going to have an intense, very intense spinning sensation. They're not going to wonder if they were dizzy. It's going to be so intense, it's probably going to take them to the emergency department. They might be admitted to the hospital, or they will be on their bed or on their couch, not moving, and they're, I hate to say it, but puking their guts out because it's so terrible. There can be two major causes to this. It can be from a central problem and or a peripheral problem, okay? So you could potentially have someone who has acute vestibular syndrome who it starts with having an inner ear problem like vestibular neuritis or labyrinthitis, but they could actually also have a stroke to their inner ear because of the anterior inferior cerebellar artery not getting the vascularization it needs, and that problem could kind of become chronic, but then they could go to having an acute central vestibular dysfunction because they're having a stroke now, because 4 or 5 weeks later, the main artery that supplied blood flow to the inner ear is now also occluded, and now it's causing stroke. So acute vestibular syndrome is usually it's usually peripheral, but it can be central, and it can be both. So I think that's important to understand. The peripheral major causes of acute vestibular syndrome you can see here on this slide. The way to tell the difference between what's causing it is whether or not there's hearing loss. So all of these, vestibular neuritis, labyrinthitis, Ramsay-Hunt, labyrinthine stroke, anterior vestibular artery stroke, all of these are going to be differentiated between whether there's hearing loss or not. So that's a huge question, is whether or not your patient has hearing loss. I ask that. Any new hearing loss, I ask that with all of my patients that I see during my history. Neuritis and labyrinthitis are due to viruses. Those patients are going to have hearing loss for neuritis. Hearing loss for labyrinthitis, no hearing loss for neuritis, but it's all due to a virus. Ramsay-Hunt is terrible because that's intense spinning with hearing loss and Bell's palsy. So that's Ramsay-Hunt. The same virus that attacks the vestibular nerve also attacks the facial nerve, right where it goes through the little opening in the skull, because the nerves go through the same opening together. Then there's a labyrinthine stroke, and that does cause hearing loss pending location, and an anterior vestibular artery stroke. So with that, there's no hearing loss. It just affects the vestibular part, but it misses the cochlea. So those are some major reasons for acute vestibular syndrome being caused by a peripheral vestibular problem. And I like this slide. You might want to hit pause and just kind of look this over. But I think the key here is the labyrinthine artery is right here. It comes off of the ICA. So if there's a stroke there, you're going to have hearing loss and you're going to have a vestibular problem. And that could be a sign that there's occlusion about to occur up higher in the ICA, which could also cause pons, midbrain pons, or pons and medulla type stroke as well, cerebellar strokes. So it's something to keep an eye on with our patients. So I explain when a patient has a peripheral vestibular problem, I like to use the life of the vestibular system. And we talked about that before, but just to remind you, and I will actually write this out for my patients. I will draw the eye guy, 100 spikes on the right, 100 spikes on the left, because they don't understand why they're dizzy. So this is where dizziness neuroscience education comes in. I'm trying to teach this in a way where you can explain this to your patients, that it will be like, oh, that's why I'm dizzy. That's what happened to me. And now I know what I got to do to get better, because they're terrified. So this is the eye guy again. Right side pulling to the right at 100 spikes per second, left side pulling to the left 100 spikes per second. As long as they're balanced, everybody's happy. Vestibular neuritis hits. Let's say it hits the right ear, and the right ear stops firing. The eyes are going to beat hard to the normal side, to the left, Okay, that's going to take them to the pit. When there's that much asymmetry, they're going to go to the pit. They're going to be super dizzy. Okay. And then I explain, here's what you got to do to get better. It's going to take about 4 to 6 weeks. You got to have a bring it on mentality. You know, I want to be dizzy. That's going to promote that vestibular compensation. I'm going to have to get off the meclizine. I'm going to have to watch my diet, get good sleep, get good exercise. I'm going to do some neck rehab. I'm going to do vestibular adaptation exercises. I got to understand it's going to get worse before it gets better. And also the feeling like I could spin is not a sign that I'm going to spin again, because many people, once they've been down here in the pit, they are terrified that they're going to go back there again. So every time they get a sense like, oh, here it comes, they think they can control it. They think they can keep themselves from going back there. Truthfully, they can't. They don't have control over that. So I explain, you know, you feeling like you could spin is not a sign that you will. Okay. So that's for kind of how neuritis, labyrinthitis works. This is a nice slide that just kind of breaks down the vascular, where each part of the inner ear gets its vascularization. So I think it's helpful to remember that not all acute vestibular syndrome is from a virus. It can be due to blood flow. And so I just think it's helpful to keep that in mind. And you won't really always know. Like the real world is that patients never really get told why they were in acute vestibular syndrome. And so if I have a patient who has a ton of cardiac risk factors, you know, they've got high blood pressure, they've got high cholesterol, they have a family history of issues, they've maybe had TIAs or strokes in the past, then sometimes I hypothesize that it's not a virus that caused their acute vestibular syndrome, that it was more likely a circulation issue. And so if we look at the central causes of acute vestibular syndrome, you know, you can have a brainstem stroke, you can have lateral medullary syndrome, Wallenberg syndrome, and you can have lateral pontomedullary syndrome. And the difference of those is the brainstem stroke is going to be lower on the brainstem, more in the medulla, and the lateral pontomedullary syndrome is going to be more of a mixture between the pons and the medulla. So I think we're looking at more of a pica stroke here and more of an Ica stroke here. At any rate, it will cause spinning that can last days to weeks, and you will have hearing loss. Just more helpful slides that if you really look into the circulation, I think it's interesting. Now, the next slide I want to tell you about is called 20-20-30. 20% of ischemic strokes occur in the posterior circulation. Okay, so the parts of the arteries that provide blood flow to the midbrain, I'm sorry, I keep saying midbrain, more to the pons and the medulla. 20% of those patients have vertigo as an only symptom. So these people only spin. They don't have numbness, tingling, weakness, slurred speech, difficulty moving an arm or a leg. And as a result, 30% of those clients are usually misdiagnosed, resulting in unnecessary morbidity and mortality. So there is something we can do about that. So I remind myself and my people who I work with that 20-20-33, 20% of the time strokes occur in the posterior circulation, and 20% of the time that those strokes occur, there are no other symptoms other than spinning, which would make a person think, oh, this is an inner ear problem. Well, not necessarily true. And that leads to 33% of people being misdiagnosed. So we're actually going to talk about how to tell the difference between a neuritis, labyrinthitis, and a stroke. But we will get there in our exam part. So stay tuned. And, you know, CT scans are terrible at finding strokes during acute vestibular syndrome. And so are MRIs. And so we have a better way. It's called the Hints Plus Test Battery that we will get to in the exam portion of this course. So hang in there. I'm going to leave you hanging on that thought and just stick with me as we go through these different problems, because what we're talking about is how to tell the difference between inner ear problems and serious life-threatening problems. So let's move on. We talked about acute vestibular syndrome just now, and now we're going to talk about triggered episodic vestibular syndrome. So these are cases that patients have dizziness that's triggered by head movements. So when they move, it causes dizziness. If they hold still, it usually goes away in a minute or less. So this can be caused by peripheral problems, and what you all have probably heard of is benign paroxysmal positional vertigo, but there are mimics of BPPV, and so it can be a little tricky sometimes. It can also be caused by central problems, and so there can be brain problems going on. The most common one is migraines positional vertigo, but you can have other central lesions that can mimic BPPV. And then you can have other peripheral problems that can mimic BPPV. And finally, orthostatic hypotension or intolerance. As you all know, that's pretty darn common, even more common in skilled nursing settings. But that is something else to consider in triggered episodic vestibular syndrome. So what I think would be good to do is just to review how do you know if a person has BPPV or orthostatic hypotension? And we used to say, describe your dizziness. Tell me, what do you mean by dizzy? And that's the whole point of this course, is going beyond what do you mean by dizzy, because there are over 435 descriptions of the word dizzy, and it's not very helpful. So people who have BPPV and orthostatic hypotension can describe their dizziness as spinning. They can also describe their dizziness as lightheaded and off balance. They can also describe their dizziness like a feeling like they could pass out. And they can describe their feeling like they actually do pass out. Now, that's not that common in BPPV. Very rarely will a person with BPPV pass out unless they sit up, and that hardly ever happens. Many will also use funny and not right. And so they can use all those words to describe the two. So the point is, description really isn't that helpful. What's more helpful is trigger. Dizziness when a person comes up from being bent over, both BPPV and orthostatic hypotension. Sitting up, yep, for both. Okay, rolling over, you'll get dizzy with BPPV, but not with orthostatic hypotension. Bending over. Now, if you ask patients and say, do you get dizzy when you bend over? They'll say yes, but what they're actually referring to is when they come up from being bent over. So I have to explain, I'm not talking about coming up from being bent over, I'm talking about being bent over. And if they have BPPV, if they bend over, they will get dizzy, and they won't. As you know, with orthostatic hypotension, you actually feel better when you bend over. So these are ways that we figure out, okay, is it BPPV or OH? Tilting the head back, BPPV, not orthostatic hypotension. Tilting the head down, yes for BPPV, no for orthostatic hypotension. And finally, if a person has orthostatic hypotension and they lay down, their sensation will probably get better. Whereas if they lie down, they will spin like a top. So that's how we kind of work out the difference between both BPPV and orthostatic hypotension. And depending on how fast the patient moves and whether they're in avoidance, all of those things can affect how the person answers those questions. Now, duration, technically, it should be seconds, but patients will also say minutes. So duration isn't quite as helpful in differentiating BPPV versus orthostatic hypotension. And of course, your objective comparisons, you're going to have, you could potentially have nystagmus with orthostatic hypotension right before a person passes out because they're losing blood to their brain. But usually they're not going to have nystagmus with orthostatic hypotension. You're not usually going to have a blood pressure drop with BPPV. They will both be off balance when they stand up. You're not going to have a positive Dix-Hallpike with orthostatic hypotension, and you're not going to have a positive roll test with orthostatic hypotension. So they're similar because they're both triggered. They last seconds. They both can lead to falls. They can both cause feelings of lightheadedness. but I think we made it pretty clear that orthostatic hypotension usually doesn't cause spinning. It's not going to happen when they roll over. It's not going to happen when they lie down. It's not going to happen when they bend over, put their head down, or put their head back. This is a slide. You can hit pause and read through this. This is how you test for orthostatic hypotension. These are the latest guidelines as of like 2016, 2017 timeframe. How you have your patient lay flat for at least 5 minutes. Then you'd have them stand for 2 minutes, and you test them at 2 minutes, test them at 5 minutes. Most of my patients that I see are more orthostatically intolerant, meaning they get sensitive when they make those moves, but they don't actually have official orthostatic hypotension. And so I will do that test pretty regularly, trying to help patients figure out what the cause of their dizziness is. And what I usually see is I'll take blood pressure immediately when they're symptomatic. And that's just called initial orthostatic intolerance. And so if there's a greater than 20 millimeter of mercury drop with systolic, or greater than 10 millimeter of mercury drop with diastolic, then we're thinking orthostatic hypotension or intolerance. And I'll talk to them about hydration and medications and stomach binders and things like that. So that kind of helps you understand some of the most common causes of triggered episodic vestibular syndrome. Now, I didn't talk much about migraine, but what we usually see is that if repositioning maneuvers work, we hypothesize that it's more BPPV, but sometimes migraine can cause BPPV. So it gets a little crazy in there, but for the purpose of this course, I want you to understand some of the major reasons why people have these different syndromes. So let's get into spontaneous episodic vestibular syndrome next. I really like this slide because it helps us understand that spontaneous episodic vestibular syndrome, meaning for no reason, the person will suddenly begin spinning or feel an intense sensation that will last minutes. And so, of course, you can have central reasons for that. You could have TIAs, you could have migraines, you could have peripheral reasons, you could have Meniere's, you could have, again, vestibular migraine that attacks more of the peripheral part. You could have TIAs and have vestibular migraine. You could have TIAs and vestibular paroxysmia. So these problems that cause this type of dizziness could be both central and peripheral. Now, I want to pause for a moment, and we're going to go to some more details of these major issues. So what I've done is I've made kind of some guidelines. And I'd like to just take a moment before we get to chronic vestibular syndrome, where you can kind of see that I have the acute vestibular syndrome, what the disease that happens, why it happens, whether or not there's a trigger, what the timing is, what the description is, and what the treatments are. So I think what I'll do is I'll point out that vestibular neuritis, the goal during the first 24 hours, and same for labyrinthitis, is just survival. Avoid dehydration, avoid falling, use a cane or a walker, use anti-nausea meds, possibly antivirals, possibly steroids, get hydrated. And the way we work through, whether it's central or peripheral, is we do the HINTS test battery. I go through lots of education for patients, dizziness neuroscience education. The goal is not to make them sick during that period of time. The pica strokes, they could be due to artery dissections or clots, aneurysms, arrhythmias, trauma to the circulatory systems, or hemorrhages. That is an emergency. I have had patients come see me in acute vestibular syndrome, and I have sent them to the emergency department, and they have had strokes. I've also had people see me with vestibular neuritis or labyrinthitis, and I always refer those patients on to their doctors or to the emergency department. While I feel pretty confident I know what the problem is, it is very crazy how peripheral problems can mimic central problems. So I err on the side of caution. I always do the hints plus test battery. I do my full oculomotor exam. But these are quick stat referrals, and you can usually pick these cases up. They're sitting in your waiting room with a trash can, and it's a quick look in their eyes, check for nystagmus, check for direction changing things happening, and it's usually a pretty quick referral to make sure that they get to their doctor or the emergency department as soon as possible. Sometimes it is a life-threatening situation. So I think I cover, we talked about BPPV. That is due to little calcium crystals loose. We went over that earlier. We're going to get into BPPV even more next, later on in this course. There's also vertebral basilar insufficiency. You know, positive vertebral artery tests, everybody always wants to know about that. I usually leave the vertebral artery out of it. I don't test vertebral arteries. I don't occlude them on purpose. I'm always aware that any head movement or head position could occlude the vertebral artery, and I'm always looking for vertebral artery signs. But I do not take people to end range on purpose, wondering if I can stimulate a vertebral basilar artery issue. I just don't believe that's a good idea. I always, though, do look for central findings. This kind of goes through, we already talked about nystagmus characteristics for central proximal positional vertigo, which would be purely vertical. It won't fatigue. It could be more purely torsional. It could be direction changing. It won't respond to repositioning attempts. I usually have a 3 to 6 visit rule for that. Spontaneous episodic vestibular syndrome, vestibular migraine, also known as migraine-associated vertigo. Some details with that is that we don't always know exactly what the cause is. We know it's a complex chemical event. We give out a migraine diet. We have a migraine handout we give that talks about possible vitamins that could be taken, possible things to talk to the doctor about from a sleep perspective, exercise perspective, vitamins, diet. We try to help patients identify if that's happening. I will often have my patients video their eyes during attacks so that we can confirm the cause and help direct them. And I have helped patients get faster diagnoses as a result of doing that. Symptoms with vestibular migraine may or may not include headaches. They could have spinning, off balance. They could have stroke-like symptoms. It may lead to emergency department visits. They can be motion sick. They're going to be hypersensitive to sound, to sight, to smell. They could have neck pain. But it's important to work closely with the doctor in those cases. These are cases where my role is to gather data and then to send these patients on. And it really, patients really appreciate that when they get a faster diagnosis. Many of these people come to see me and they're being told they have BPPV, and that's not the case. So take a good history. It's often genetic. There's often a familial history. And, you know, you could try treating it as if it's BPPV, but if it's spontaneous, if the attack comes on for no reason, that is clearly not BPPV. Another common cause of spontaneous episodic vestibular syndrome, which actually we think is less common than what we originally thought, is Meniere's disease. That's going to have that intense spinning sensation that's going to last hours, sometimes minutes, but most of the time hours. and there will be a full feeling or pressure feeling in the ear with hearing loss. So that's important to consider. And some of the latest people that I'm listening to who lecture on this stuff, they are really saying consider vestibular migraine before you consider Meniere's disease. That vestibular migraine can actually cause the same exact fullness in the ear, hearing issues, hearing loss, and they treat it as though it's migraine, and they've had better success than treating it as though it's Meniere's disease. So again, try to see the client during an attack. Try to video their eyes during an attack. If a person is having Meniere's, their eyes will beat to the strong side, to the side that's actually having the Meniere's attack. And then after you see them a few days later, their eyes should beat in the opposite direction, if at all. So Meniere's is an irritative lesion, so it causes a hyperfunction, not a hypofunction. So vestibular paroxysmia, Meniere's, and BPPV causes hyperfunctions, and neuritis, labyrinthitis, inflammation, head injuries can cause vestibular hypofunctions when they affect the peripheral vestibular system. Head impulse test. I don't usually see a positive head impulse test when a patient is having acute vestibular symptoms from Meniere's. Okay. So I think those are some of the biggies that I wanted you to know about with spontaneous episodic vestibular syndrome. Chronic vestibular syndrome is where we're heading next. There is a condition called persistent postural-perceptual dizziness. Now, this used to be called phobic postural vertigo. Then it became chronic subjective dizziness. And it is believed to be triggered by vestibular problems, where now they also have psychological issues involved, because it's very terrible to be dizzy. So what we try to do is prevent acute vestibular syndrome from becoming chronic vestibular syndrome. So, or spontaneous episodic vestibular syndrome from becoming chronic, or triggered episodic vestibular syndrome from becoming chronic. Because it's terrible. The feelings of dizziness that come with 3PD are constant sensations that usually are not triggered, but they have extra sensation of dizziness that can last seconds, that can be triggered by head motion, by watching things move. Sometimes they're more sensitive to heights, sounds, and odors. And I'll get into that more here in a moment. Some of their symptoms can last seconds. Some can last days to weeks. Some can last years. They'll likely have a baseline feeling of dizziness that doesn't go away. And they may describe their dizziness as spinning, but you won't see any nystagmus. They might feel like they could spin. They might feel a rocking sensation, a swaying sensation that never goes away. And I'm going to tell you more about my take on 3PD here in a moment. And so what I do is my goal is to make them the best version of them that they can be. I try to optimize their overall health, try to make them as healthy as they can be from a inner ear perspective, a brain perspective, an aerobic, spiritual, and mental perspective. And so we do a lot of cool things with patients to help get them there. And it seems to be more likely in patients with OCD, depression, anxiety, but it doesn't have to. They don't have to have those problems to be in 3PD, but it seems to be more often in those individuals. It's believed to be a true neurologic problem with behavioral elements, and I've seen that. So this diagnosis term came out, I think, around 2016 or 15. I kind of have a way that I described it back in 2003 or 2001, and I didn't make this up. This was just what I observed, was that there'd usually be a dizziness trigger. So usually a patient would be in BPPV, for instance, or they would have had acute vestibular syndrome, or they had vestibular migraines, and their brain stopped trusting their inner ear. And so they went through what we called sensory reweighing, and they become visually dependent. So they rely a lot on their eyes for their balance, which makes them dizzy anytime they see things move in front of them. So anytime you have a patient who says they get dizzy watching things move, if they're sitting still, you know they have visual vertigo or visual dependence, and you automatically think, oh, they're in this cycle. Okay, so this is huge. And many of these patients, their necks will tense up and they'll get neck pain. Their head will feel full, pressure, foggy, fuzzy, and the neck tenses up. They start to feel normal movements of sway as abnormal. So these are cases where, when we stand up, we all feel this constant sense of movement, but we don't acknowledge it. It's unconscious. It's kind of below our awareness. But when you have an inner ear problem or a brain problem that involves the vestibular system, the unconscious becomes conscious. So you start to sense normal feelings as being abnormal, and that makes you tense up. It makes you not want to move, and you get what I call scared stiff. You start to avoid doing things. And if you don't do something, if you don't use it, you lose it. And now when you do go to move, you actually feel off balance. Okay, see how we're working our way around this vicious cycle. And then you get afraid of falling, and that causes height vertigo, which is fear of falls on your own 2 feet. I had height vertigo at the CN Tower in Toronto. Felt like a big wimp standing on the glass floor when my wife's running around on it doing jumping jacks, and I'm frozen, looking down, feeling like my stomach feels weird, my head feels weird. But that actually causes dizzy sensations. And so then people start to use their hands for their balance. They develop anxiety and fear of becoming dizzy, which also causes more dizziness, which actually triggers more sensory reweighing. And our patients are in this vicious cycle. So what I've done is I've made a paper that actually explains each element of this vicious cycle and how to help patients get out of it. And I have used this for 20 years, guys, and it has worked very, very well. And patients love to understand why they're dizzy. I know 3PD is a common word to be used, but I actually had one doctor was irritated about that diagnosis because he felt like you're labeling people. And I kind of see his point. I like to explain their dizziness more from this perspective, in that we just break the vicious cycle. We figure out what the trigger was, we fix the trigger, and then we start to treat every single one of these elements on this vicious cycle. Okay, there are things we can do for people in every single one of these different stages, and that's what we'll get to under treatment. So if you look at this is the 3PD explanation, and you're going to see that it's extremely consistent or similar to what I just explained as the vicious cycle of dizziness. And so feel free to hit pause and kind of read through some of this stuff, but you'll see it's very similar. So when it comes to what's wrong with people, why are people dizzy? I usually find it's not one thing. And I like to say it's the dizzy pie. I had a student make this for me, and it's usually that they've had BPPV. They also have an inner ear weakness because they're 75. Their ear got sick one time 25 years ago, which made them a little more likely to have BPPV, and they're getting macular degeneration, and maybe they have a little bit of neck tension, neck headaches. They've got some neuropathy going on, and all these different things are causing their dizziness, and they want to know, why am I dizzy? Well, it's every different thing is causing different dizzy sensations, and it's my job as a therapist to figure out which one it is and to help patients work through it. So this is similar to what I would see, and I call it the dizzy pie. I'm starting to use the word buckets, dizzy buckets. I don't know if patients understand dizzy pie as much. I used to love that, and I would draw this out, and I would write each thing out and how we go about treating it. And this is usually what I see. This is a patient that, they're usually have a lot of these elements. And so we would talk about that, but I'm starting to use the word buckets, and I think that helps. But this is kind of how I see the pie. They got a vestibular problem. It's central and peripheral. It's stable. It's new on old. They also have an eye problem that's stable. Maybe it's macular degeneration. It's being treated. It's new, on old. If it's unstable, things could be changing. Or what if they have heart problems that, they're in AFib and they're being treated for that, but the medications needed adjusted lately. And so that was stable and then it became unstable. Now it's stable again, and how that can make people feel different sensations in their head. They could have anxiety that's coming and going. They could be depressed that's coming and going. It could be stable at one moment and then unstable the next. It could be chronic. And all these different things make people dizzy. So this is how I see the patient with dizziness. Now, something else that I think is really interesting that I've got to share is the individual with dizziness. Okay. If you've got a type B person who's a minimizer, they're not going to be as alarmed about their inner ear problem as a type A obsessive compulsive, highly sensitive person. Now, Elaine Aron identified the highly sensitive person. She says that 15% of the population hears more, sees more, feels more. And they're more in tune to their spiritual world. They're more in tune to they can walk in a room and see who's happy, who's sad. They are moved by the arts. They are very talented from an artistic perspective, but they also feel more. They have all the feels. They, a 4 out of 10 dizzy for a non-highly sensitive person could be a 9 out of 10 dizzy for a highly sensitive person. So check this out. It's really cool. These are just questions. There's a highly sensitive person test. If you Google it, or if you click on this link, if your patient's highly sensitive, a highly sensitive person with BPPV is different. They're going to explain their dizziness differently than a highly sensitive than a person with BPPV who's not highly sensitive. So check that out. Pretty cool stuff. I have actually had patients. I have had a few artists, a few very, very, very talented artists, famous artists, where they've drawn pictures like this. And I should get some of my other pictures because this is pretty amazing. Then I also have other pictures that are amazing of different individuals. Think about people who can draw stuff like this, your engineers, your artists, your highly in tuned people to their world. If they can pay attention to this kind of detail, imagine what happens when they get an inner ear problem and how that might affect them. So they're going to describe their dizziness different when you're trying to figure out which syndromes your patients are in and whether they're in the vicious cycle and what their dizzy pie is. You got to think about what their personality is that could be the underlying variable that's making it a little more confusing. That's why triggers, timing, and nystagmus, the big three, are key. Helps you work through this stuff. Okay. So this just kind of explains that a little bit more, how these individuals see their world different. Type A sees their world differently than a type B person. Now the patients who are anxious, who tend to be anxious, they're going to be on the edge of their seat. They're going to be intense when they're talking to you in their history. They're going to be more likely to be hypervigilant. They're going to be more aware of all their symptoms. They're also more likely to hold their breath and hyperventilate. And many of these patients are in the fight or flight response. And they're going to describe also feelings of floaty, lightheaded, and other dizzy sensations, in addition to BPPV type dizziness or neuritis or labyrinthitis or whatever. So in addition, because their world is so much more heightened, they're more likely to remember their experience, which means it's going to hang in there for them longer. And I think sometimes this leads to post-traumatic stress disorder for some of our patients. So pretty interesting. And these patients so much appreciate when we take time to explain why they're dizzy. Okay. And so I hope that what you're figuring out is that there's a way to educate people. And I'm using some tools that I use in the clinic that I call it, pain neuroscience education is becoming very popular. And I like dizziness neuroscience education. We go through the anatomy, we go through the physiology, we talk about vestibular compensation and how it works. But we got to take time to explain why their problem's present, explain that the feeling that something could happen is not a sign that it will happen. They're going to get the pre-spins. These individuals are going to always feel like they're on the verge, like it's going to happen, but it doesn't. Give them a home exercise program to help confirm the presence or the absence of a problem. For instance, if they come to you with a diagnosis of BPPV and you can't find it, give them a home exercise program to make sure that they don't have it. Have them video their eyes during an attack to help gather more data. This is all very helpful, and it will help these individuals dot their I's and cross their T's, which can go a long way with helping them get out of that vicious cycle of dizziness. And so rehab will take longer for these individuals, just like it would for patients with back pain or, shoulder problems or whatever. So again, the big three is key: triggers, timing, and nystagmus. Be an investigator, be a detective that helps these patients figure out what are their triggers, what is their timing. I have one lady right now who she could not describe her dizziness. She's all over the place. So I actually have her, I don't like to do this actually, but I have her keep a journal because most people pay too much attention to their symptoms, but she just can't describe anything. So I'm actually trying to figure out, is she in spontaneous episodic vestibular syndrome? Is she having triggered episodic? Is this anxiety? She's a smoker. I think there's a cardiac component. She's being worked up from a cardiac perspective, but we're trying to figure out, is there BPPV? So I'm having her do home epiles. I'm trying to figure out what's going on, and I'm using this. I wanted her to video her eyes during her attacks. It's very helpful to use some of those strategies. And I will use this diagram, the life of the vestibular system. So for a person with disequilibrium of aging, they're not going to go to the pit fast. They're going to have a slow, gradual decline. So they're just going to feel off balance from time to time, and we've got to teach them about, well, as life goes on, your inner ear doesn't work as well as it used to. You're going to have times when you feel off balance, but you got to work and be the best version of you can be. We teach them some inner ear exercises, get them doing some balance exercises, and we help them work through the fact that their inner ear is going to get weaker as time goes on. Or, this would be a case of Meniere's. So they have a person's going along, they have a Meniere's attack, they're going to have a hyperfunction in the moment, but then their ear gets sick. So then they drop down, they're back to a hypofunction, and then they got to compensate. Okay, so as time goes on, that's how this whole system works. Here they're going to feel spinning. Here they're going to feel spinning. Here they're going to feel off balance. Now they're going to be back to about normal. But they're not going to be as good as they were before. And every time they have an attack, they're going to get a little bit weaker and a little bit weaker. That's how it works. Now, if you take a person who has Meniere's and BPPV, so here's their Meniere's attack, okay? They're going along, they keep having Meniere's attacks, but now because their ear's sick from Meniere's, they're more likely to have BPPV. So they're having spontaneous episodic vestibular syndrome plus BPPV. So it's all working together. This is a case where you've got the right ear and the left ear with disequilibrium of aging. So your left ear is good, but when your left ear is good, your right ear is bad. And then when your right ear starts to get better, your left ear gets bad. That's the joys of aging. But that's how this kind of stuff can work. And so that's similar here. This is kind of what I see of a patient who's in the vicious cycle of dizziness. They're, disequilibrium of aging here. Their ears become unbalanced. They got back pain. They got neuropathy. Oh, now they get BPPV. Now they're not going to trust their ear anymore because it's getting weaker, and they're getting BPPV. So they're going to rely more on their eyes for their balance. They're going to use their hands for their balance. Then BPPV comes back because it comes and goes. Well, of course, their neck's going to stiffen up. They're going to get some pain. They're going to get headaches. Oh, there's BPPV again in the left ear, and they had it in the right 3 years ago, but now it's in the left. And now they're becoming afraid of falling. And, this is how we explain what's wrong. And as therapists, we got things we can do to fix it. So it's so cool. But we've got to help patients understand what's wrong, and using the tools I've talked about, okay, talking about videoing your eyes during an attack. Do some home epiles, try to figure out what's wrong. There are many things we can do to help these individuals get better. Okay, so next section, we're going to talk about objective exam. How do we know what's wrong? We're going to do well, first, before objective exam, we're going to talk about the history. How do we take a good history? How do you work through these cases to figure out which syndrome they have, whether they're in the vicious cycle? The other thing I want to draw your attention to before I conclude is I've got the common problem screen. I'm going to try to sneak it in under here. This is my common problem screen. So if you've listened to all this and you're thoroughly confused, this is a very simplified, here's how I figure out what's wrong with patients. And here are the questions that I ask. And these are the common things that I see. So we'll get to this in more detail during our history section, but I want to draw your attention to this, because if you just study this 2-page form and you're working with patients who are dizzy, you're going to be led in the right direction to make sure that you are heading in the proper direction. So let's conclude the pathophysiology section by going over the objectives for this course and making sure that we covered them. So our first objective was to explain how the peripheral vestibular system changes over time in the presence and absence of pathology using the life of the vestibular system diagram. So I think you guys would agree that we covered that pretty well, that as time goes on, our inner ears get sick, we're going to feel different sensations and different types of things are going to come on, and we have things we can do about that. I think now you feel like you could compare and contrast those 4 major syndromes. You know the difference now between acute vestibular syndrome, where you spin like a top for, several days to week, to chronic vestibular syndrome, where you're feeling kind of foggy, fuzzy, full, and that can go on for months. I think now you feel you could define what acute vestibular syndrome is, and that that vestibular neuritis and labyrinthitis are peripheral problems, and a stroke would be a central problem. And triggered episodic vestibular syndrome, I think you could figure out the difference between BPPV and postural hypotension. And spontaneous episodic vestibular syndrome, we talked about vestibular migraines, Meniere's disease, and TIAs. Chronic vestibular syndrome, we discussed anxiety, panic disorders, briefly touched on cervicogenic dizziness and 3PD. And then we discussed that vicious cycle of dizziness and how that can cause all kinds of different sensations in people's heads. And we discussed who the highly sensitive person is. And then using that dizzy pie to organize the different problems that you see and to help patients understand why they're dizzy. So, hey, this is exciting stuff. Thanks for listening. We're going to get on to the history part next. So hang in there with me. Keep going. Email me if you have questions, and we'll see you soon.